Great. Good evening, everyone. Thank you for being here. This is the 5th annual lecture of the Institute of Global Health Innovation. We've had some distinguished speakers before. The first was the Lancet editor-in-chief, Richard Horton, followed by the ex-CMO, Sir Liam Donaldson, and most of you will also remember Julio Frank's lecture the year before last. And last year we had Nubar Ofayan, who was the founder and partner CEO of the Flagship Ventures. This year, it's a great pleasure and privilege to introduce to you our speaker, who's Professor Meltzer, who is the Chief of Section of Hospital Medicine, the Director of the Center for Health and Social Sciences, and the Chair of the Committee of Clinical and Translational Sciences at the University of Chicago. He's also a professor in the Department of Medicine and affiliated to the faculty of the Harris School of Public Policy Studies and the Department of Economics. Obviously, he's a jack of all trades. He's received his MD and PhD in economics at the University of Chicago and completed his residency in internal medicine at the Brigham and Women's Hospital in Boston. Since then, he has led research exploring problems in health economics and public policy with a focus on theoretical foundations of medical cost-effectiveness analysis and the cost and quality of care, especially in the dreaded teaching hospitals. He's an elected member of the American Society for Clinical Investigation and serves on the Secretary Advisory Committee for Healthy People 2020 as an advisor to the Congressional Budget Office and on the Council of the National Institute for General Medical Studies. As you will expect, he's a recipient of numerous awards, including the Lee Lusted Prize of Society for Medical Decision Making, the Healthcare Research Award of the National Institute of Healthcare Management, and the Eugene Garfield Award from Research America. We're very much looking forward to hearing your talk, David, which I understand will focus on patients at high risk of hospitalization and whether you use comprehensive care physician model that can improve the care of these patients. I still remember many years ago, there was something in Downing Street called the delivery unit. And we went out there and they were looking at the KPIs in relation to the reform of the National Health Service. And at the time, it was chaired by a very distinguished senior civil servant. And one of the challenges facing the NHS in these elective treatment centers was comorbidity. So when he asked the question, huge amount of confidence, he asked the CEO of the NHS and the experts on that panel who were presenting their KPIs, what does comorbidity mean? The response was when there is more than one thing wrong with you. And his response was, I deal with those every day. They're called politicians. So on that note, really look forward to your lecture, and thank you for being here.
Great.
Thank you.
Thank you. So it's really an honor to be able to talk to you, and I think it's going to be hugely beneficial to me because I think particularly for this project, I have a tremendous amount to learn from you. This is a project, as Ara said, about reforming care for the highest risk patients in the US healthcare system. And the model that we've developed is called the comprehensive care physician model. And so I'm going to begin by giving you some background about these high cost patients and then gradually work you towards the model we've developed and my thoughts about how it may be useful. I'm also going to hint at some results of a study we're completing that I think is going to yield some really exciting results and talk a bit about the implications of that. So let me say that this study is funded by the Center for Medicare and Medicaid Innovation. I'll talk a little bit more about what that is in a moment, but it's an institute created by our Medicare program. And I need to put this up wherever I present it, just saying that these are my opinions and not those of Medicare or the Department of Health and Human Services. So I I think in many countries, but perhaps particularly in the US, when we think about the challenge in changing healthcare, it's really driven ultimately by the incredible increases we've seen in healthcare costs. You can see here the numbers in the US from about $27 billion spent a year in 1960 to about $3.2 trillion today, so a 100-fold increase. And as a percentage of GDP, from 5% to just a staggering and world-leading or trailing, depending on how you think about it, 18% in 2014. And spending a lot of money on something isn't necessarily a problem, but when it's something that comes through government financing, it really quickly becomes unsustainable. And you can see here a figure from a Congressional Budget Office report that shows really an incredible growth in the share that health spending will take in the US GDP over time, from right now, the relatively good days of about 5% to numbers more like 10% as we move ahead. So, we really have to do something. And as you look at this growth, it's very easy to think that the growth of healthcare is inexorably going to rise. But in fact, there are some amazing stories of real reductions in healthcare expenditures with payment policy. So this is a figure that shows the growth in Medicare expenditures on hospitals in the United States. The blue line in the middle is a period that separates before the establishment of Medicare's prospective payment system to afterwards. So the Medicare prospective payment system in the US changed us from paying additional monies for every day in the hospital to a fixed amount of money per diagnosis. And what you can see is that before that point, we were averaging annual growth rates of up to about 13, 14% a year. And then as soon as Medicare prospective payment came in, the annual rate of decrease in real terms fell to about 6-7%. So public policies can really change expenditures. Now, this is one of the lessons of the efforts to control healthcare costs over the past couple of decades in the US, but I don't think it's the most important. If I had to choose the single most important, it would be the fact that's embodied in this slide. And what this shows is the incredible concentration of healthcare expenditures among a small fraction of the people. So this is Medicare spending. And if you look at the top 5%, 10% of beneficiaries, you can see the top 10% is responsible for 85% of the expenditures. Conversely, the bottom 90% is responsible for, actually let's look at the top 25. The top 25 is responsible for 85% of the expenditure. The bottom 75 responsible for only about 15%. Moreover, if you look at the level of spending among that vast majority, that 75%, it's a few hundred to a few $1,000s per year. And that's really not very much money. And almost any money you spend trying to reduce those costs, you're going to have an extremely hard time making back. And what that means is if you're going to engage in interventions to reduce costs, the place you have to focus is on this top 25% of people that are responsible for 85% of the money. And this is what's sometimes called in the US Sutton's Law. Sutton, not the economist, but the bank robber, Willie Sutton. When he was finally caught after many decades of successful bank robbery, he was asked, why do you rob banks? And the answer was, well, that's where the money is. Right? So if we want to decrease expenditures, we have to focus on the high utilizers. And that's going to be an absolutely central part of what I talk about. So in comes the Affordable Care Act in the United States in 2010. Two parts of it. Part of it is about increasing access to insurance and insurance market reform. But in terms of actually reducing costs, it's really a set of payment and delivery system reforms that are going to matter. And in the US, there's been a lot of rhetoric around many of these things. And unfortunately, a lot of it is not well supported by data. So there's belief that prevention will decrease costs. And if you actually look at the literature, it's a vanishingly small number of preventive interventions that really decrease costs. Some, if you think of this as disease management, but I think that's really rather separate. Comparative effectiveness research. So we've had no NICE in the US. We couldn't agree even on the term comparative effectiveness, so we had to call it patient-centered outcomes research. Even that was too controversial for us, so we had to decide that it could say absolutely nothing about costs. So we did create this Patient-Centered Outcomes Research Institute, but it has almost no chance of meaningfully identifying costly, ineffective therapies and reducing costs. So then there's care integration. So lots of people understand that care is often poorly integrated. In the US, this has been embodied in this principle of a patient-centered medical home. These are practices that have staff in them that are designed to reduce costs. The problem with this is it's become a policy to save primary care in the United States. And so often these staff are being put into practices and assigned to patients who have very little expected costs. So as I said before, it's impossible to actually save money on this. So this too is very unlikely to be successful. Then we have bundling and capitation, strong, powerful incentives to reduce utilization. Bundling meaning payment for a fixed episode of care, capitation being fixed payment for a year of care. We know from the literature and experience that these significantly reduce costs. The effects on outcomes are a little bit unclear. However, these models have not grown much in the US. And so there's been this idea of creating what's called accountable care organizations that would integrate across loosely connected providers to do this. And there's almost no evidence that this actually can be done successfully. So there's a lot of uncertainty here about how this might actually play out. So within that context, in comes the Center for Medicare and Medicaid Innovation, which was given $1 billion, that's with a B, $1 billion a year for 10 years to figure out what works in healthcare, thinking explicitly about these ideas of cost and quality. And what's most amazing about it is that the Secretary of Health and Human Services was given the ability to implement, without the involvement of Congress, whatever is shown to work. And as you know, in the US, not involving Congress these days is an important thing if you want to move reforms ahead. And then finally, the last component of this is reinvestment in the primary care workforce. And underlying this is the belief that American medicine has become way too specialized, that we don't have enough primary care doctors, and that primary care doctors can do a lot of these other things. They can integrate care, they can prevent illness, those sorts of things. And this is an area that, in a sense, is the jumping off point for what I'm going to talk about, and something that I've been interested in for really almost 2 decades. So the context here is this incredible growth of specialization in the United States. This is a figure from about 2000 showing the incredible growth of specialization in the United States after the establishment of Medicare in 1965. This is the growth in the number of generalists in the United States, essentially flat. And that's the growth in the number of specialists. There's been some of this sort of pattern in every developed country, but nowhere has it been as extreme as in the United States. And there's a belief along with this that specialists are responsible for increasing costs without really improving outcomes. Some of this belief comes from studies such as the Medical Outcomes Study, which did the most careful job ever done at the time of comparing the costs and outcomes of patients with heart disease and also diabetes who were cared for either by specialists or generalists. And what the study found was that the patients cared for by specialists had higher costs and worse outcomes than the patients cared for by generalists. And so this led to an argument that the US needs more primary care doctors. Now, I read this as a student trained in economics and was skeptical. Why? Because who goes to specialists? People who are very sick and want a lot of care. So we should hardly be surprised when they don't do that well and they spend a lot of money. So this is not a great study design. But it got me interested in this question, really, of what's the right degree of specialization for American medicine. And so what I'm going to do now is lay out a bit of a theoretical framework for that problem and then lead up to the particular application and intervention that I'm going to talk about that come directly from that theory. So when I think about this problem, I approach it using my training first as an economist, really the sort of classic economic theory of specialization. And within economics, that really begins with what is, in fact, the first sentence of The Wealth of Nations. And in it, Adam Smith writes, "The greatest improvement in the productive powers of labor and the greater part of the skill, dexterity, and judgment which is anywhere directed or applied seem to have been the effects of the division of labor." In other words, we become more efficient and productive as a society because we divide up tasks among ourselves. And then Smith goes on and talks about the story of the pin factory, where by dividing up the tasks, from the old pin maker who used to do everything to one person who finds the ore and another melts it down and another turns it into wire and another cuts it and another sharpens it, they're each able to become more efficient in those tasks so that overall we become much more productive. And and because these tasks have been divided, Smith then argues that we need markets to coordinate them. As he tells this story, he talks about the mechanism of advantage, which are of these pin makers. But they're fascinating because all these apply to medicine. Improved dexterity from repetition, the surgeon who gets better the more they do. Saving time otherwise spent switching between tasks, going from hospital to clinic or whatever else you might do. Application of machinery invented by workmen or others, so the development of human capital and knowledge. So all of these apply to medicine. Now, Smith was an extraordinary economist, and he understood that there couldn't just be benefits of specialization because there had to also be costs or people would be infinitely specialized. And he argued that the division of labor was limited by the extent of the market. And in the context he was writing, the extent of the market was determined by the total demand for product and transportation costs and, of course, the cost of building an empire. Okay? And the more modern statement of this is rather different. It's that the benefits of specialization are limited by the costs of coordination. The more you separate tasks among people, the more effort needs to go into combining them, the more costly that is, and the more scope there is for effort. And so the modern statement of the efficient division of labor argues that the efficient division of labor balances the benefits of specialization on the one hand and the costs of coordination on the other hand. And this work is significantly the part of my thesis advisor, who was Gary Becker. And this has been widely cited work and unfortunately not so widely tested. Now, what I've just told you is economic theory. There's also sort of theories in medical ethics. And in the US, one of the classic texts that is taught in medical ethics is one on the importance of the doctor-patient relationship by Francis Peabody, who was a Harvard professor in the 1920s. And the most often cited sentence is this one: the treatment of a disease may be entirely impersonal. The care of the patient must be completely personal. The significance of the intimate personal relationship between the physician and patient cannot be too strongly emphasized. In other words, you must focus on the patient. Don't be so specialized on one point of their illness. Understand all of it. Now, what's interesting is that if you read that paper carefully and you read the part other people don't, and you keep going, you discover he also says, you know what, you better have some specialized knowledge too. So you should know something about the kidney. So he actually says there's this same tension between, on the one hand, being a generalist, and on the other hand, being a specialist. This same sort of theory is actually common even in the popular press, or in popular culture. So many of you may never have heard of Marcus Welby. Marcus Welby was the most popular television character in the United States in the 1960s and early 70s. And he was a family doctor. He did everything. He saw healthy patients in clinic. He made house calls. He looked through the microscope. He could learn things just by looking at tubes of blood. He operated. He delivered babies. And this is my favorite picture. He even knew how to find an otoscope in the hospital. I don't know anyone who can find an otoscope in the hospital. And this is his famous quote: "We don't treat fingers or skin or bones or skulls or lungs. We treat people, entire human people." So this sounds a lot like Francis Peabody. What's fascinating is if you actually watch this show, and I was not born when it was on TV, but I watched it on YouTube, it shows exactly the same tension of lacking specialized knowledge as well. And so all of these theories emphasize that specialization is a balance of costs and benefits. And the right way to think about this is to understand those. Now, there is one more theory that's essential for me to mention. And this is a theory I think many of you may not be familiar with. It's a new economic theory of specialization, and it's called an adaptive organization perspective. And the idea is the following: if you're in a situation where you have very high coordination costs, so you kind of want to be a generalist, but you also have increasing returns to the division of labor, so you kind of want to be a specialist, a firm may simplify its product to reduce coordination costs. And in doing so, you reduce the specialization. So here's an example. Think about an old-style sled, which at least in the US had wooden top and metal runners. Okay, that was pretty expensive. You had to get them to fit together. What's happened since? We make them all out of plastic in one piece, but we simplified it to do it. It now doesn't turn, right? But it's much, much cheaper. And so what's the medical analogy? That you think about different ways to solve problems. So you use new technologies like bariatric surgery to treat diabetes as a way to simplify that management. You use practice guidelines and you standardize care to use lean approaches. And what I'm going to present to you is really a lean approach to the organization of care of complex patients. And as I'm going to talk about here, focus team care on simpler cases where care coordination is easier. And ironically, do not use teams in the most complex patients to the extent many people are doing now. And as I'll show you, there's good evidence it doesn't work. So let me now turn to the context in which I'm going to describe this in the US. And it's really this growth of the field of hospital medicine. So I need to explain this a little more here than I would in the US, perhaps. So traditionally in the United States, we had primary care doctors who cared for patients in the clinic and then in the hospital also for their general medicine problems. So these doctors would start their morning seeing their own patients in the hospital, and then in the afternoon they would have clinic. And with this, there was this incredible emphasis on the value of continuity of care and the doctor-patient relationship, this sort of Peabody idea. As much as this was dogma in the US, this model is almost unique in the developed world. And then in the mid-1990s, things changed dramatically in the US. We started getting these hospitalist physicians, who are physicians who spend at least 25% of their time in inpatient care, and the vast majority of them now spend all their time in inpatient care. And there are more than 30,000 hospitalists today. They're caring for more than 1/3 of all general medicine admissions. It's the fastest, largest change in specialization in American medicine, certainly in the past half century. And the question that I got interested in is really, is this change in specialization a desirable one, and why did it happen? So there are really two theories here. The first theory is that hospitalists grew to meet the needs of hospital care. The idea was that as hospitals with Medicare's prospective payment system had the incentive to cut hospital length of stay because they were getting paid a fixed amount of money, they wanted to cut length of stay. Hospitalists could do this because they were there and focused on it. Patients were getting sicker in the hospital, where they were only sicker patients were getting into the hospital. They needed to be there more. So this is the theory that almost everyone believes. But if you look at the actual data, it's nowhere near as convincing. There's data that hospitalists save about $750 to $1,000 per admission. That's an absolute maximum. The savings grow with experience, but as I said, that's a maximum. And there's data that shows there's absolutely no effect on post-discharge costs to Medicare, which in many of our complex patients are $100,000 or more per year. So huge amounts of money, and we're not really moving the needle. So this is not a game changer by any means. And what about value to the patient? The outcomes are similar in every dimension. In essence, people have looked at this. If anything, we know people prefer having the physician they know and not a physician they don't know. And they're not willing to pay much, about $200 per admission to get that. But nevertheless, this is not clearly improving things. So why in the world did it grow? And this gets to really the second theory, which is that hospitalists grew not to meet the needs of patients, but to meet the needs of ambulatory care, and particular primary care doctors. And the basic story is that over time, primary care doctors experienced declining hospital volumes relative to ambulatory volumes. And this is not because hospital volumes fell, it's because ambulatory volumes rose as more and more patients sought preventive care. What this meant is whereas previously the doctor could see patients just in the afternoon and have plenty of patients in the hospital, now they were seeing patients all day long and barely had any patients in the hospital to justify the trip. So they were traveling in there for a few minutes, turning around right away, and not able to really provide good care for those patients in the hospital. And this is a figure from a paper we published recently showing from the 1980s to the mid-2000s, an 80% decline in the rate of hospital admissions relative to ambulatory volumes. So the epidemiology of healthcare just changed, and doctors' jobs had to change to fit it. And in fact, as doctors organized themselves into groups of physicians, this encouraged specialization because they would just have one of their partners go and the rest would stay in clinic, and pretty soon those doctors became the hospitalists. Now, I've just described a theory for you about why hospitalists grew. I'll tell you, we've actually tested this formally as an economic theory. The way we did this is we compared the time costs of two models from the perspective of physician time. The traditional model, in which the internist spends their time seeing patients at the hospital and in clinic and then has to drive back and forth. And the newer model with a hospitalist and a primary care doctor, where the hospitalist spends their time seeing patients in clinic, but now has to call up the primary care doctor. And similarly, the primary care doctor spends their time the hospitalist spends their time in the hospital, has to call the primary care doctor. The primary care doctor spends their time in clinic, now they have to call the hospitalist. So the difference is they're spending all that communication time. So it's transportation time on the one hand and communication time on the other. And as you do the analysis, it becomes clear that the cost of the primary care hospitalist model compared to the traditional model is driven by per capita communication costs compared to transport costs for the typical internist. And this equation, which is replicated from a National Bureau of Economic working paper, really shows exactly this, that the difference in cost for the PCP hospitalist model compared to the traditional cost model is driven by communication costs. This is how likely patients are to be admitted, that pie, and the cost of communication because the more they're admitted, the more communication you have to do, and this is transport costs relative to the number of patients you care for. And so what this tells us is that the cost of the PCP hospitalist model compared to the traditional model will fall as admission rates fall relative to ambulatory visits. I just told you that happened. As communication costs decline, which you can imagine happens as communication and technology gets better. As transport costs rises, which we know they do as hospitals grow and cities get more congestion. And then finally, as physician work hours decline, which in the United States they did dramatically, both because more and more women entered primary care, and traditionally in the US, women work fewer hours than men, even when they're doctors. And also more and more men were not willing to work as many hours as they had. So all these trends were happening in the US. And what we did is we got data on measures of all these trends from something called the Community Tracking Study. And then we tested using that study whether this predicted the likelihood that a primary care physician would choose to rely on hospitalists for their patients. And every single one of these theoretical predictions was supported by the data. PCPs were more likely to use hospitalists when their patients had a lower probability of hospital admission, when there were all these measures of lower communication costs, as transport costs rose, and as they tended to work fewer hours. So we concluded from this that there was strong empirical support for this theory that I described. And in fact, all the trends, falling admission rates, falling communication costs, rising travel costs, and falling physician hours, all supported this growth. And these are pictures from Marcus Welby of him seeing a healthy patient, him on the phone, him unhappy waiting in traffic. And this is the young partner he took on who wanted to ride motorcycles and not work long hours. So I've just said all this, I won't repeat it again, but it left me with a fundamental question. Is the use of hospitalists really an economic necessity of changes in ambulatory care, but perhaps not really good for patients who are hospitalized? Now, why do I say that last thing? And the reason I say it is there is this extraordinary literature on the value of the doctor-patient relationship, especially for complex patients. So this literature on the doctor-patient relationship emphasizes trust, interpersonal relationship between the patient and the doctor, communication between the patient and the doctor, and knowledge of the patient, all of which come from having a durable relationship. And there's independent empirical studies, multiple ones for every one of these. We know that patients value seeing their own doctor in the hospital, even if they won't necessarily pay a lot. There's also an empirical literature showing outcomes. So we have observational studies that show lower costs and better outcomes with greater continuity of care. So Medicare patients who are cared for by their primary care doctor for more than 10 years have 15% lower Medicare costs. Lung cancer patients who are cared for by their own doctor in their terminal hospitalization, presumably a known diagnosis and obviously fatal, have 25% lower use of ICU care. Again, much more appropriate care. Now, these are observational studies. You can criticize them for that. There's an experimental study, which I think is one of the most extraordinary studies I've ever read, by Jack Wasson and colleagues. He studied about 800 patients in our Veterans Administration in the 1980s who were randomized either to see the same patient, the same physician in every visit, or a completely different primary care physician in every visit. And what did they find? The continuous care group had 49% lower emergent hospitalizations, 38% lower hospital days, and 74% lower ICU days. I mean, these are totally extraordinary results. So I conclude from this that discontinuity is harmful and costly, especially for these complex, frequently hospitalized patients. But this leaves us with a real dilemma. We would love to have the doctor see the patient both in clinic and the hospital, but I just told you it's not possible. It's not practical for them to do it. So how do we solve the problem? And the solution that we came up with is really to stratify the patients according to their expected hospital use. So if the problem is the doctor doesn't have enough patients in the hospital, what if we had a set of doctors who just focused their practice on patients at high risk of hospitalization? So they could have a relatively small clinic, small enough that they could see it only in the afternoons. But every morning from that small clinic, they would always have patients in the hospital. So that's the idea here. We take all patients. If they have low expected hospital use, they get an ambulatory-based primary care doctor, and in the rare instance they're hospitalized, they get a hospitalist. For the high expected use people expected to be in the hospital, they get one of these comprehensive care physicians, or sometimes we call them a primary care hospitalist. So what would be the advantages? The most frequently hospitalized patients would get their own doctor in both settings. Patients value this continuity. They want a doctor they can see in both settings. This decreases unnecessary testing and treatment. The continuity actually makes the doctor's job easier. It's much easier for me to care for a patient in the hospital I've already seen and know than a patient I don't know. So they can actually bill quite a lot and just as much as a regular hospital-based doctor would do, in fact, more. All hospitalized patients get doctors with significant hospital experience and presence. These doctors could even be specialists. Patient choice is restored. They can choose their doctor, which they can't with a hospitalist. And this is a model that can work feasibly for the physician because their panel size can be smaller, and yet they can bill just as much. This can work within a patient-centered medical home or bundling or with readmission penalties, so because it decreases utilization. And you can also use this to build a very small primary care base for a hospital that can help fill beds. So if you're a small, struggling community hospital that needs to fill bed but doesn't have the capital to buy a lot of doctors to work with you, you can do that. What are the challenges? Will enough patients be willing to switch? Will doctors let patients switch? Will doctors even do this job? And can it be economically viable? So let me try to talk through some of those, but I want to start with the economic viability issue. So people have been talking about improving care coordination, at least in the United States, for decades. And if you think about this, sort of summarizes the challenge. If you think about each of these bars as spending, right now we spend a lot of money on the hospital and a little bit of money on ambulatory care. And our goal is to shrink the size of this bar. Well, we're not going to be doing it by getting rid of ambulatory care, maybe a little bit, but not much. We got to pay now for all this care coordination. So we have to decrease hospital spending a lot to make this work. And so this is going to be hard to do. And we know it's hard to do because if you look at Medicare's efforts to improve care coordination, and this is a summary of them by the Congressional Budget Office a couple of years ago, of 30 some odd efforts, they conclude on average they do not save money. Some of them decrease hospitalization, but on average they do not save money. And they stratified them by whether fees are at risk. Didn't really make a difference. They did seem to work a little better when there's direct interaction between the care manager and the patient, and the physician rather, and between the care manager and the patient. Let me explain that. The vast majority of these programs work by hiring extra people in the team to do care coordination, while fundamentally absolving the physician of the responsibility for doing that. Okay? And none of these are dramatic savers. And the problem is you just can't make back that money. There are a couple of other lessons. Target interventions to high-risk enrollees, so focus on them. We do that in this model. Gather timely data on the use of care, especially hospital admissions. We're heavily focused on that. Focus on transitions in care settings. Our model explicitly bridges the inpatient-outpatient transition so that we don't have to spend a lot of effort making that work. And we use team-based care, although we use it but very sparingly, as I'll talk about. And then limit the costs of the intervention. Don't hire a lot of people if you can't make the money back with them. So what's been the research approach? We started by talking with physicians and practice leaders to understand what the challenges were. We then did a series of implementation and pilot studies, including complex predictive modeling to identify patient risks at high risk, patient groups at high risk of hospitalization. When all was said and done, we figured out we could do this incredibly simply. We asked one question: have you been hospitalized in the past year? That's the only inclusion criteria. That and Medicare is enough to make this work for us. And then we built simulation models using operations research research methods to model the feasibility. And then in 2012, we got money from the Center for Medicare and Medicaid Innovation, about $6 million, to over 3 years to develop and begin to test this model. So let me tell you a little bit about the model and its key design elements. We focus on high-cost patients. These patients who've been hospitalized at least once in the past year, these are expected to spend about 10 days per year in the hospital, and it's about 40% of our general medicine days, and annual Medicare costs of probably a little less than $150,000 to $100,000 per year. And we recruit all over the place, including residents, clinics, in the emergency room, and in the hospital. We maximize the direct interaction of the patient with the doctor. We do so by limiting the panel size to only 200 patients per doctor, compared to 2,000 or 3,000 for the typical primary care doctor. But I want to be clear, they have no fewer encounters than a typical doctor. They just have them concentrated in these high utilizers. They spend their mornings on the ward seeing their own patients. They have a little time off in the middle of the day, and then an afternoon in clinic. We built an interdisciplinary team with 5 doctors together seeing 1,000 patients. We organized these doctors as well as APNs, nurses, social workers, and so on around the patient's medical and psychosocial needs. We don't add anyone more to the team of any doctor than is any patient that is absolutely needed. So we try to emphasize one individual or smallest possible set of individuals being responsible for a broad scope of care. So we have these small, well-connected teams with provider continuity. We also try to improve care transitions with post-discharge calls and health IT. This is actually a minor problem for us. We're preparing for financial incentives with cost savings, and I can talk a little bit more about that later. We work very hard to develop sustainable roles and training for the care team. The mortality of this group is probably about 15% per year. The average income of our patients is $20,000 family income per year. These are incredibly needy patients. So we have a lot of psychosocial support, not just for the patients, but for the doctors. We use rapid cycle innovation techniques using frequent data-driven meetings that engage the relevant leaders in our institution. And we're doing a really rigorous evaluation, a randomized design, 2,000 patients, 1,000 in the intervention, 1,000 in the control, using Medicare claims data and external and internal evaluators. So let me tell you a little bit about the status of this. When we started the program in 2012, we had to have weekly design meetings, operations meetings. Literally, we built this almost from scratch. We had to hire doctors, APNs, social workers, clinic coordinators, set up the informatics, and even the clinic. We had to build an evaluation and design and implementation strategy. We had to get IRB approval. So that happened in November of 2012, and we began randomization. We've now recruited about 1,350 patients. The rate is gradually growing, half in the intervention, half in the control. The panel size of the doctors has grown up to about 150 patients per doctor. Each doctor has about 3 patients in the hospital each morning. So that gives you an idea of their workload. I am not allowed to present the results because the study is ongoing and Medicare has limitations on that. What I can tell you is we've had incredibly positive interim qualitative and quantitative results. We have population health metrics. They're driven by an evaluation plan, things like satisfaction with care, health status, hospitalization rates, and so on. We also take this data on individual patients and use it to help the doctors improve care. We have weekly meetings where we run through the list of hospitalized patients and literally target the high utilizers and figure out what we can do for them. I can tell you we could pay for this entire study with just one of our patients if we just got that one person not to go to the hospital so much. We have weekly discussions of complex or informative cases. These are incredibly instructive. We're now in a stage where we're really trying to address longer-term issues, such as the financial model for expansion and sustainability. We see many ways to do that. This model is so inexpensive to run that we can almost make this work in fee-for-service in the United States, even with Medicare's reimbursement rates. We're basically growing our clinical volumes to use these doctors' time well, and Medicare just recently approved these chronic care management codes, which pay an additional amount per month to care for a complex patient. Our biggest challenge is that there's a copayment for that, and our patients are so poor that they can't afford the $8 a month that is charged by Medicare for that. We're also positioning ourselves for risk-based contracts, trying to keep the cost of our program low, trying to do coding that documents our risk severity, and trying to arrange the contracting of this, which deals with a set of complex risk selection issues. But we see both of these as very viable options. In terms of the future, we expect to finish the study at the University of Chicago by June of 2017, at which point we should have enrolled 2,000 patients and had at least a 1-year follow-up. We're looking actively at partnerships with others interested in the model. At the University of Chicago, we're just starting a Medicare Advantage program, which is a capitated Medicare program, and we're talking to a large private payer who would benefit from these reduced costs. The model's been implemented in a place called The Villages, which has, in Florida, it's partnered with the University of South Florida. It's the largest private retirement community in the US. And they have a network of community health centers, and each one has hired a comprehensive care physician who then also connects into the local hospital. We've applied for Medicare for some money from the Transformation of Clinical Practice Initiative, which is supposed to help disseminate new models. We've been talking with a large urban academic medical center that serves a very poor community about doing this, a large urban county hospital system that is interested in this, and a community hospital that's seeking to increase its occupancy, as I mentioned earlier. So we're looking at many of these. I want to just end with some thoughts about how this fits into the health system as a whole. If you think about what we've done so far at the University of Chicago, we have a big hospital and a clinic, our DCAM clinic. We have 5 doctors who just basically cross the street and do this. At the Villages, it's much more diffuse. Each one of these is a little neighborhood with a clinic, and the doctors come from that neighborhood clinic into the hospital. Not super far away, 10-minute drive, but distributed. Some of the new models we're looking at begin to sort of be hybrids of some of these. So this is a community hospital, the one I described, trying to fill beds. And they have sort of a bunch of loosely affiliated clinics they could have some connections to. And then they have one clinic that they're a little more connected to, and they could have multiple doctors doing that. You can then think about how does that fit into the bigger healthcare system. So this is the south side of Chicago. This is the hospital where I work with the clinic associated. Here's this community hospital that I'm talking about. And I had the opportunity a few weeks ago to meet the director of a clinic that sat right in between. And what he told me is, we send patients to your hospital. We also send them to this other hospital. I wonder if there would be a way to have a doctor who did both, or 2 doctors, one who went to each, which is much more practical. And what that begins to suggest is a broader vision of how this fits into a health network. You could imagine that hospitals, that CCPs serve as bridges to create a clinically integrated, patient-centered network, connecting hospitals to multiple clinics and connecting clinics to multiple hospitals. This clinical integration would be promoted by provider continuity, same doctor in each place. The CCPs could have access to both the clinic and the hospital's electronic health records. So you don't have to have a single electronic health record. You just need to have the login and remote access. This could save a few $1 billion. The CCP would be accountable to both of these institutions. One of the things I really like about this is it's really agnostic with respect to ownership, so who owns these practices. And in the US, what's happening right now is all these systems are being bought up. It's agnostic with respect to who employs the CCP and even the payment model. This has extremely low capital requirements. You don't have to buy the whole system. You don't need a lot of doctors either, because this is a small number of doctors focused on the highest needs patients. And you don't have to buy a lot of healthy information technology. You can benefit from the unique reimbursement systems and advantages in clinics and hospitals. These clinics get paid for ambulatory care much, much better than our hospitals get paid for ambulatory care, so you can take advantage of that. It's consistent with competitive markets, which can have benefits in terms of both efficiency and autonomy. These health centers do not have to be bought out by these healthcare systems. And that, in turn, has huge costs when they are in terms of lack of competition. And so it's really a structure that allows for a competitive market. And again, it's consistent with either fee-for-service payment or a capitated system or the sort of hybrids that's a shared savings model. So over time, my thinking has moved from a clinical model that really begins with the patient towards thinking about this from a healthcare system. So thanks so much for all your attention, and I'm happy to take comments.
Thank you very much, David, for your excellent lecture. We'll now open the floor to questions from the audience. Please let us know your name and affiliation.
Sure.
Well,
Hello, my name is Chris Edwards. That was a wonderful lecture, David, very much enjoyed. I wonder whether you comment about the applicability in the UK, because obviously we have a very different structure here. I mean, for many years we have been refighting the First World War. We have two trenches, one is called a hospital and the other is called primary care. And the two sides completely fail to be complementary to each other, spelt both with an E and an I. So your model is a different one, and I just wonder if you'd comment on that, and also if you'd like to comment on the question of what do you think this means we ought to be doing in terms of changing the education of doctors?
Yeah. So I don't know a lot about the system here, but my understanding is that these two roles are quite separate. My belief is that this is fundamentally driven by the epidemiology of illness, and that there's a small set of people who are very ill and walk between these two places, go between these two places, and that it is extremely difficult for doctors to function in that environment. They spend a tremendous amount of time relearning things that were already known. They lack all these connections to the patient that I think can be extremely valuable. So my sense is that there's huge opportunities to do this in many places. Now, what does that require of the doctors? It requires that you be able to care for patients in the hospital and be able to care for patients in clinic. I don't understand enough about clinical training here to comment, but I will tell you that in the United States, this is how we actually train young doctors. And then what happens over time is they forget it. They focus in one place or the other place and not both. And so the largest group that we've seen of people doing this is people who come straight out of training. But we have seen extraordinary hospital doctors who are great at all the complexities of hospital care and want that durable relationship with patients. And they need to relearn a little bit of primary care. And we've also seen primary care doctors who've had that expertise in primary care, but always seen patients in the hospital and kept up their skills, but just not seen the same patient in the hospital. And so we've had no trouble finding people to do this. One of the things I really want to emphasize is you don't need a lot of doctors to do this, and you certainly don't need it early on. I mean, I think like all these models, they need to be tested, right? And in any given setting, they may or may not be the right thing. My sense is that we probably have lots of young doctors who could do this, and individuals from both the primary care world and the hospital, I guess, consultant world who could do this as well. And so I think it would depend on the individuals, and we've tried to do education on both sides to help them, and that education's been useful. I mean, things like basic preventive care or dealing with palliative care, those sorts of things are things that hit both sides.
Hello, my name is Hutan Ashrafin. I'm a clinician academic at Imperial College. Thank you for your talk. Would you be able to tell me a little bit about your thoughts on accounting for temporality and variation in the efficiency of your team? So volume load of patients at different times of the year, etc.
Yeah. So, there are ebbs and flows in all of these things. It's busier in the winter. We see that certainly. The most important observation about temporality, though, is not about season. It's actually about temporality in the program. The most striking finding is that in both our intervention and the control groups, patients get better over time because they either get healthy or they die. And it's a very rare person who can stay super stick very long. And so one of the critical findings is that if you're going to make a program like this work, you have to dynamically balance the panel in terms of who you bring in. If I were to put 200 newly admitted patients in this program in a doctor's panel, they would be completely overwhelmed. But if you start putting them in gradually, then it can really work well. And that's the single most temporal aspect of this. The other thing I think in your question a little bit was about variation. And at this point, we have experience with about 6 or 7 doctors doing this job. It's a very small number. I don't think the study is going to be heavily influenced by any one of them. But I do think that obviously we need to look at larger numbers and more places in order to really know. And so what we're doing right now is looking for, as I said, partners to do additional studies.
Okay, over there. Yes, but you have on there. Okay, good. Yeah. Yes. Yes.
Hi, so it's John Connolly from Department of Health and part-time Masters in Health Policy in Imperial. I was just wondering if you could tease out a little bit more how you stratify patients. Is it based on cost, disease burden, value?
Yeah. I said it very briefly. One question, basically, have you been hospitalized in the past year? And if the answer is yes and you have Medicare, you're eligible. And the reason we chose that is that we wanted to find a group that was high enough risk that the doctor would have enough patients in the hospital on a daily basis without being overwhelmed in clinic. But we didn't want it to be such a small group that we couldn't find enough patients for a doctor to fill their practice. So we didn't need to focus on the ultra-high utilizers, just high enough. And honestly, it was a wild guess. But it worked out beautifully. I mean, the numbers are exactly tracking to where we wanted, which is very fortunate. And the great thing about this is you can put it in a newspaper ad. People can explain it to their friends. It's very easy to understand. And I think it's, at least in our setting, good enough. And if we got it wrong, we just dynamically adjust it over time. But the best single predictor of future hospitalization is past hospitalization. And that's essentially what we're doing.
I'm sure there are a large number of senior general practitioners here, but coming back to post-war, in 1948, a general practitioner actually had, in most cases, they were single-handed. They had a small list, and they were responsible for the care of that patient both in the community but also in a hospital setting. In actual fact, consultants like me, the reason they're called consultants is because they were there to consult, no different than the McKinseys. And the primary care physician took their advice or ignored it. So no surgeon could operate on the patient without the consent of the primary care physician or the prescription of the primary care physician. And I think one of the interesting things about the past is that the consultants weren't employed by the hospital. In actual fact, they visited the hospital. So that allowed that flexibility to do that. So in many ways, we are revisiting the past, but with more intelligently by stratifying the patients. And it's phenomenal to go back and look how we run the system before, where we are at the moment.
Great.
Okay.
Hi, thanks for your very inspiring and quite mathematical talk. I'm Taslo Fogle. I study health management here at Imperial. So I've noticed the problem that at the moment in life we make many good decisions, but a few great decisions. And so currently I'm founding the company Plandle, which crowdsources decision making to offer people with a database with a vision to empower people to make great decisions. So my question to you is, what 3 things have helped you make a few great decisions, and what have you learned that you wish to share with us?
Complicated. Yeah. Having great teachers has been wonderful, who teach me ideas from different disciplines. So the model that I developed that gave me this sort of insight was something I was taught by Gary Becker, my thesis advisor. It's sort of elementary microeconomics. I guess I'll also say sometimes not focusing has been very useful. When I think about this project, it's a little bit of economic theory, it's a little bit of clinical medicine, it's a little bit of management, it's a little bit of policy. And I don't think that you could put this together with any part of it. And then the third answer will be the throwaway of, I don't know what the third answer is. There are many more lessons than you could ever summarize, but having good friends helps.
Ali McGuire from the LSE, is this on?
Yeah.
So the way you set it up, David, was there's additional benefits from coordination and the costs of specialization have grown too large. But I suppose there's always going to be a balance between these two things. And so whilst you're experimenting, I recognise, but going back to GP list sizes, there'll be a volume coordination issue. And what's your sense of the optimal size of these new clinics?
Yeah. So again, there is this tension between sort of too much and too little specialization. And, as I mentioned, this adaptive organization perspective does provide a way out, which says sort of there are some things you just can't do well, so you should just focus on the things you can do well. And in this case, fortunately, the thing you can do well is care for these really sick people who happen to be spending a lot of the money. So I think, I don't know how to fix primary care by and large. But I think that primary care for very sick people, I think we can do better than we're doing. So I think one thing I would say would be focus on that. From the perspective of the scale of these practices, we organized them with 5 doctors. And the reason I did it was very simple, which is that I wanted those doctors to cover the weekends. But I didn't think that I could help people have sustainable jobs if they were working more than 1 in 5 weekends. And so I wanted that group of 5 to be able to do that. And it's really interesting. If you look at general internists in the United States, they're heavily women. If you look at hospitalists in the United States, they're heavily men. And although gender roles obviously are much different than they were, there still are those forces. And one of the fascinating things about these comprehensive care physician models is that they're working for people of both genders. And I think that's actually, and family responsibilities, even put gender aside. And I think that's really critical. So I think you want to build a sustainable model for the doctors. And in our case, 5 doctors was a good number. If I had 10 or 20 or 30, I would break them into groups that were all a little different. I would imagine a group of 5 GPs who did this. I could imagine a group of 5 cardiologists who did this for, people's problems who are mostly, cardiac in nature or pulmonary in nature. I visited some hospitals in China that are just on this extraordinary scale where you could have that sort of specialization. My hospital is not that big. We're about 100 general medicine beds, and we just couldn't really do that. Maybe even less than 100 general medicine beds. So, again, I think about 5 is the right, I think you could do it with 4, you might be able to do it with 3. We started with 2, and we built up.
But in terms of the workload, you mentioned that you're going to phase in patients, not to overwhelm doctors with patients who have just recently been discharged from hospital. Yeah. But we know that some of these patients are likely to be high cost, high need for a very short period of time, others for 2 or 3 years, and a small percentage for 7 to 10 years.
Yep.
So how are you going to develop predictive analytics to take this into account?
So I'm very sure that you could do a better job of predicting these long-term outcomes. We don't have the data right now to really do that very well. These are very selected groups, but we've thought a lot about it. Right now, I'll tell you, it's working. I do have some ideas about how to do these predictive analytics. One of the tools that we've been using recently is something called sequence analysis. So there's sequence analysis in genetics, and there's a tool called social sequence analysis that basically looks at the order in which events happen. And what you do when you do that is, this is my favorite example of this. Think about someone who has a heart attack and a hip replacement. Okay? In traditional risk models, you get a point for each of them or something like that. In these models, we look at the order in which they happen. So if someone has a hip replacement and then they have a heart attack, that sounds bad. On the other hand, if they have a heart attack and then you hear later they have a hip replacement, that tells you it must not have been a very bad heart attack. So what you can do is combine the order of these events to do predictive modeling. We've done this and published a paper looking at it in community-acquired pneumonia, and it substantially improves the predictive ability. So we're really interested in trying models like that. Right now, we're getting this to run. We think over time we may be able to fine-tune it and improve it. But right now, we've been able to do it. And the one last thing to say about this is what I said before is true, that you can dynamically adjust this. So that if I get it wrong to some extent, I can fix it by putting these sort of very sick patients in the doctor's clinic.
There was a question over there. Oh, first you and then you. Yeah. Yeah, you go. Okay.
Thank you very much for your talk. My name is Essen Rao. I'm the research fellow from Department of Surgery. Since I've got the mic, I'll take the opportunity to ask 2 questions.
No, just one question.
One question.
Yeah.
So I can understand that managing a patient with multiple morbidity is a team task and a multidisciplinary approach. So like having a CCP model, would you also recommend having a specialist team for continuity of care?
Yeah. Yes and no. So what we try to do, the problem with teams is that when you ask someone else to do something, it takes both your time and their time. And it's not clear they'll do it. And what I think has happened in healthcare is that we have confused the idea that having a well-coordinated team is a good thing with the idea that having a team is a good thing. A team is a necessary requirement under some circumstances. Okay? When there's absolutely no way one person can do it something, or when it's very costly for them to do it. So I think that what's often happening in healthcare right now is everyone's talking about caring for the patient, but no one's actually doing it. Okay? And so the goal is to have the smallest team possible for these patients. So we try to avoid teams. Now, that much said, we recognize that there are times when it makes sense for someone else to do something. So for example, there may be, for a given patient, some underlying social determinants of health that really we're not the perfect person to address. Now, what do I mean by that? I don't mean a patient's psychological situation, because I think that the doctor can signal to the patient how important that is by, in fact, being engaged in it. But if, for example, what they need is a ramp to get them out of their home, or they need help signing up for social services, then we need to get the right person to help them do that. But there's a temptation, particularly in medicine, which is so hierarchical, to just dump tasks on other people. And I think we've gone way too far with that. And what I'm trying to do is push back against that.
Adrian Bull from Imperial College Health Partners also thoroughly enjoyed this discussion and talk. But from the hospital perspective, I can see this is a move to generalization. But from primary care, does this not result in specialization? So as you create the cadre of primary care physicians who can deal with these sickest patients and get the experience in doing so, do we not then de-skill the other primary care physicians who are no longer looking after these sick patients? And what are the effects if this were to spread across the system in that way?
Yes.
Is that not a paradox?
Yeah, it is in a way. But let me try to address it, and I'll add another paradox, which I could also try to address. So I think there is some truth in that. And I think, that a lot of what primary care doctors do in many instances could probably be done by advanced practice nurses who are well trained. And so I don't feel totally bad about that to the extent it happens. I also think that there's incredible science behind really good behavioral change and preventive care, and that I think there's a very rich career for many primary care doctors in doing that. And in the US, we have an incredible shortage of primary care doctors anyway, so I'm not sure that it's the same issue. The other thing I'll say, which is where I thought you were going with this issue, is there is a discontinuity that's created in this model, which is that if someone's had a primary care doctor for a very long time and then they get sick, is it at that point are you going to then throw them to this other doctor? And my answer is no. There is a company, CareMore, which was purchased by WellPoint, thank you, which does something slightly similar to this in the US and has not been very successful, at least as I understand it. And my understanding as to why it has not been successful is it tried to force patients to go to these extensivists, they call them, rather than letting them opt in. What we do is we only let them opt in. So, and often it's a discussion between the patient and the primary care doctor and a reasoned decision. Many of them, frankly, don't even have primary care doctors. So I think that if you don't force this, but you create it as an option, you minimize the downside that is raised in that. And I think that's a very good option.
There's a question up there.
Julia Riley, palliative care. Many of these patients, if you look at patients, 1/3 of patients in a hospital will die within the next year. So many of the patients you're talking about are terminally ill. And in London, we've done the reverse of what you've done. We haven't reorganized our medical staff, we've reorganized patients. And we've set up a service called Coordinate My Care, where we do two things. We ask the patients what they want. And we've shown very clearly when patients design their own care, it's less expensive. And the second thing we do is we connect it to the urgent care services. So we have a telephone 24-hour service and the London ambulance service. So my question to you is, do you ask the patients what they want in their care plan? And when you've got their care plan, how do you organize it so these care plans suffice 24/7? They're not just when your doctors are visiting the clinics.
Yeah. So I think that patient engagement is a really important issue in all of this. And it's something that the whole healthcare system, probably worldwide, but certainly in the US as well, is trying to learn how to do better. I think that patient engagement automatically begins to happen better when you are constantly engaged with the patient because you see them. Right now, if one of these doctors screws up and the patient doesn't take their medicine and ends up in the hospital, they see them there. If they send them home too soon without thinking about what their home situation is, they hear about it in clinic the next day. So just the structure of the relationship drives this. And that doesn't mean we don't teach it and talk about it and engage in it. We try to also do formal care plans. But the engagement of the doctors in these patients is profound. It's amazing. None of the doctors in this program, I think, are bad doctors. I think they're all good doctors. But I can tell you that I watch them change as physicians, having continuing responsibility for patients. They had forgotten what it meant to really be responsible for a patient no matter where they were. And they were re-educated, not by me, but by the process of caring for those patients. And when we talk about the individual cases, and when we do this in every one of our program meetings, we run the list of the patients and we talk about individual cases. And it really changes them. And you mentioned sort of end-of-life care, and I do want to just take a moment and talk about that. We've tried to train all these doctors in palliative care. We, of course, have palliative care consultants. But what we try to do as much as we can is to bring palliative care into the regular part of the doctor-patient relationship so that we don't have to say, now we're treating you to cure you and now you're in palliative care. It's really a continuing discussion about goals of care. And I think one of the things that makes palliative care so hard for many physicians is this feeling of abandonment. And we really don't have that in the same way because no matter what the goals of care are, we're there. Now, there are, of course, limitations. If we do home hospice, it's hard for us to be there all the time. We can't provide the 24/7 coverage. On the other hand, one of our 5 doctors, who is one of these comprehensive care physicians, doesn't have a clinic. He does home visits as his ambulatory care. So he starts his morning in the hospital and he does home visits in the afternoon for these homebound patients. And when other doctors' patients need that home care, he'll go and see them. And he's often met them before because he also covers the inpatient service. So I think these are some of the things that we can do to try to address some of the issues you're talking about.
Yes, please. Over there.
Hi, I have a lot of friends from America, and I can see the patient there, they suffer from the trust with the doctor because the insurance company, and they know that if they are insured, the doctor would be greedy with them. So how can that affect your, working?
Yeah, so in other words, what are the financial incentives that the doctors may have in this model, and does it affect them? We haven't had a lot of discussions of that nature. It's interesting, the closest discussion we've had is only very recent, and it's with these chronic care management codes. Because we basically have to have a conversation with the patient and say, do you want this care management service? Right now, that service was only approved, I think, January 1st. Okay? And we've given it for free, and now we're asking them to sign up for this and pay that $8 a month. And some of them say, well, I was already getting this. Why should I pay? And the approach we've taken is very transparent. We say, well, we're going to give it to you regardless. But we want you to know that if you agree to this, we get the $8 from you and we get $32 from Medicare. When you put it all together, that's enough money that helps us keep this program in business. So if you can afford it, we'd love it if you'd sign up. And if you can't, we'll still care for you. So we try to be as honest as we can about it, but it hasn't come up as a really obvious issue.
Okay, I think we have to conclude our event here. It has been a great pleasure to have the opportunity for both me and I think for all of you to listen to David's excellent lecture and be able to engage with him tonight. David, thank you very much again for your excellent lecture, and we're most grateful you could find the time to be with us today. On behalf of the college, let me offer you a small gift.
Oh, thank you.
It is not high cost, but it could address a high need occasionally.
Okay, wonderful.
Thank you very much.
Thank you. It's really an honor and a pleasure. Thank you.